there's a couple intro things I want to go over quickly, which are mostly just kinetic things and talking about the differences between age groups and how we treat them a little bit differently. So just some definitions I'll be using throughout the lecture. Premature is generally less than 36 weeks gestation. And then those kids are still considered like in the premature category up until the 1 month post birth. They're still kind of at risk for those premature diseases. Once they get past the 1 month, and they're a little bit out of the woods, more or less, they should be doing better at that point. And then term neonates, they're greater than 36 weeks. Infant, 1 to 12 months old. A child, technically 1 to 11. Adolescent would be 12 to 18. So with kids, you have a number of different things that we assume as far as absorption goes. So with PO medications, you have some considerations to take here. Decreased gastric motility, generally, decreased acid secretion, increased GI transit time, and increased percutaneous absorption. So a number of these would, of course, this one would be, of course, affecting creams, ointments, and stuff like that. Kids' skin is thinner, so anything's going to absorb quickly. We talked about steroid creams. Remember, with kids, stick to low potency or medium potency for the most part. And then as far as GI stuff, you can't really control this too much, but as far as dosing goes, just make sure you're following the dosing recommendations for kids, which is an obvious statement, hopefully, but it's something that we want to make sure we're doing. If you don't work with peds a lot, make sure that this is something, if you work in a mixed population group, always look it up. And even if you're working regular with peds, there's going to be things you're going to memorize, which is fine, but there's also going to be things you're going to have to look up. And just make sure you're not mixing up your MIGs and KIGs, and making sure that, the person recorded the weight in pounds and kilos. We've had some issues with that in the past where somebody put pounds in as kilograms and we, gave a much larger dose than we intended to. So stuff like that happens, and it's human error, but just always keep that in the back of your mind. The dosing can be a little bit challenging with kids. With distribution goes, it changes and generally stabilizes once you reach kind of early childhood or late childhood, I should say. So distribution with protein binding, newborns have decreased albumin. Usually that's going to be cause them to have higher levels of free drug floating around. And again, 7 to 12 years of age, usually you've got adult levels by then. That's pretty much par for the course for a lot of what we're talking about here. Free water changes. This chart shows a little bit of the differences in body fat percentages and total extracellular and total body water. Now, this doesn't make a huge difference again, but what we're looking at is the extracellular water and the body fat composition. It kind of goes up in the early infant years there, where you're going to have higher distribution potentially of lipophilic drugs. So that's really the only thing we're thinking of. But again, it's not that big of a difference. So the question is how much does it really matter? And again, we dose things appropriately. So drugs that are studied in kids or studies looking at optimal dosing in kids don't necessarily take these things into consideration directly. They might not say, okay, we're going to look at specifically how lipophilic this drug is and how much it distributes throughout their system. You might just look at, okay, how effective is this Tylenol dose for managing this child's pain? And they can measure blood levels too and to see how that goes. So we don't necessarily know which tissues it's building up and are getting to. We just know that some differences vary with different age groups. Hepatic enzyme activity, of course, is one of our things we love the most about drugs and understanding their metabolism. So this is one of the things that is a bit easier to understand, I think, than the rest. The other two things, distribution, protein binding, kind of theoretical impact. This is pretty solid. So when you're looking at hepatic enzyme activity, neonates start pretty slow. Infants ramp up towards the end of their first year of life, and then child adolescent are really fast and peaks usually during the toddler years, and that remains pretty fast through the young adult years too. We'll usually slow down probably in the mid-20s to early 30s, start to taper down a little bit. So by the time you're a toddler, essentially, you've probably got a full enzymatic activity on board. So the really big difference here is with the neonates who have that really slow metabolism. So that's where you have to take some consideration. And you probably aren't going to do a whole lot of neonatal medicine unless you go and practice in a neonatal hospital or neonatal practice. So it's not going to affect a lot of you, but possibly. There's different oxidation and phases affected. So conjugation and oxidation are affected. Clearance is predictable in adults, but can really vary widely in children. So I just put a half-life example in there. Morphine has active metabolites. So you can see like neonates half-life 7.6 hours, and then it slowly gets decreases as the child gets older. Even up to 2.5 years, you can see it's like a third of what it was. So it definitely changes drastically for the different age groups there. And some of the more common enzymes, like 3A4 activity, takes a lot longer to reach than maybe some of the other ones. And it just varies. So I think I have a chart here on the next slide that shows you some of the more common ones. If I can get back to this. So you can see the different activities. So this UGP2B7, you're like, what is that? That's a conjugation enzyme that we don't talk a lot. That's a phase 2 reaction. But you can see that younger kids don't have a whole lot of that at all. So what they do have is some of the CYP activity that builds up slowly. But it's really that phase 2 that kind of kicks in, so that additional metabolism, which we don't care a ton about, but there are some drugs that are affected by that. So again, we take that into consideration when we're looking at pediatric dosing and when they're developing those dose guidelines. So it's not something you really have to think about too hard. But if you're thinking about drug interactions in kids, like if you work in epilepsy and you're treating a young kid with a seizure, it just might be something that comes into play. So there's with drug interactions and things like that. But again, not a huge deal, just something to keep in the back of your head. All right, eliminate. So renal function is going to change too. So related to gestational age, and usually landmark developments are at 22 weeks and 34 weeks gestation. So if you have a child that's born pre-34 weeks, they've missed a mark of renal development, and so that can affect their clearance at birth. Usually pre-22 weeks, not going to make it, but maybe in some odd cases they could make it that young. It's not impossible, but it doesn't happen all that often. But anyway, term infants, if they're go to full term, they will have a relatively high creatinine clearance, as any parent here probably knows. Urine production is fairly high, or it should be. And we do a little bit different equations for kids, though. We don't necessarily use the Cockcroft-Gault. We use something like the Schwartz equation, which uses age and body length as a constant, uses an age-related constant and also looks at body length. And serum creatinine isn't really an accurate marker at all in newborns. Their muscle masses just isn't developed, and they aren't metabolizing creatinine or eliminating creatinine like an adult would. It's not really a metabolic byproduct that they're producing as much of. So, like for hospitalized infant, urine output is key, so that's what you're going to be measuring and looking at. You do that in adult medicine too, but much more so in child medicine. So if you want to go into pediatric, like acute care, that's something to get very familiar with. And we really don't rely as much on like GFR or anything like that. You can use the Schwartz equation again. There's a couple other ones out there that I didn't mention. Again, it could develop or change depending on what practice you're working with, and different hospitals may have different protocols with different equations. From preterm to adolescence, volume of distribution goes down. Creatinine clearance should go up and start to come into play once the baby fat phase kind of goes and they have more of a normal, I guess, musculoskeletal system. And then I put an example of gentamicin, which is pretty much a purely renally cleared antibiotic. And in neonates, 4 to 12 hour half-life. So again, even with the neonates, a really big range, very unpredictable. And then child and adolescent, 1.5 to 2 hours, so much more narrow focused target there. So you can see that it varies, and different kids are going to develop differently, of course. So that's why, like for example, with gentamicin, we don't use it a lot in adults anymore, but we do use it for some neonatal stuff, and it's something that we get levels on and check blood concentrations on if we're going to treat somebody with it, especially a neonatal patient, because it's so unpredictable what type of clearance they're going to have. But usually once a kid is 6 to 12 months to age, that's close to adult half-life for renal function. So again, just like hepatic function, it's really those little kids, so pre-6 months and the early neonates, that are in that different group where you can really have to remember that, okay, metabolism and clearance is quite different in these kids. And this is just a chart showing GFR versus para-aminohippuric acid is a biomarker they used in this study. Think about it like creatinine, it's just another way you can look at it. And so they did a GFR calculated by that based on days old and age. So, I mean, it predicts pretty much how you would think it would, right? It's going to increase slowly over time. All right, generally speaking, smaller sized people require smaller doses. However, if you multiply like a mg per kg dose for a kid, like let's say you say 10 mg per kg, and you multiply, or 15 mg per kg, let's say that. So that's a common dose for Tylenol. And if you were to give that to an adult who's 100 kilos, you'd give them a 1,500 milligram dose. So that's probably not something we're going to want to do. That's too much for one dose, right? Max for Tylenol dose is 1 gram at a time. So just to put it in perspective, yes, the doses are going to be much smaller, but actually if you scale it up relatively, they could be larger because we're taking into account of generally higher metabolism, especially for our toddlers. And that's a big piece of the puzzle. And that's, again, these doses are designed to calculate for that. So you don't really have to think about this too hard, but just know that if you're trying to use weight-based dosing on an adult from a kid's book, well, I don't know why you'd do that, but let's say you were, you might be like, well, this is way higher than what it normally would. And that's why sometimes when you get a really heavy kid, they might cap out on their top dose. So a lot of times they'll read pediatric dosing recommendations that say max dose, and it caps out at the adult dose. Usually you won't go over that. There are some exceptions, but that varies depending on the disease. So again, look it up based on the indication and based on the drug you're using. Double check the weight. I can't say this enough. Double check the weight. Always look at what the weight is in the chart. Look at the kid. Make sure it all matches up. And again, mg per kg per day versus mg per kg per dose. This gets a little confusing, especially with antibiotics. Sometimes they'll say like 50 mg per kg per day divided up into 2 to 3 divided doses. Okay, well, you can figure that out, right? But if it says mg per kg per dose, remember that that's going to be specific for each dose. So just think about those things and try not to overdo the math too hard in your head, because it's not that bad of math, but just remember that there are differences in how they recommend that sometimes. And it does get a little confusing occasionally. So what if you're using some drug and there's not really a recommended dose? Is there a guideline? There is sort of a rule of thumb that you can divide the child's weight by 50 kilos and multiply that by the standard adult dose. That should get you sort of a child dose. There's some other equations out there that I looked up. This is the simplest one, so I didn't want to get too into the weeds on this, and there's some studies looking at these, but generally speaking, this is sort of a tried and true easy method for something that you're not going to have any data on. That's going to be an odd situation you're going to be in, and hopefully, I don't know if I've ever been in that situation. I don't do a lot of peds medicine. We do a little bit of pediatrics through some of our satellite ER that we support, but other than that, we don't. And I've never had it come up where there's not any child data on any of the medications we're using. So again, unless you're doing like specialty care or something like that, you're probably not going to see that come up. Studies in children are pretty much lacking across the board. There's, of course, ethical considerations when studying kids and putting kids in clinical trials. The FDA has incentivized drug companies to do this, so what they give, I think, is a 6-month patent extension if they can prove or put out some pediatric data. So when a lot of the psych medications, like some of the second-generation antipsychotics and antidepressants, were going close to their patent mark, they came out with these pediatric literature studies to extend their patent another 6 months. So sort of the FDA's way of saying, you can make an extra however many millions of dollars off exclusive sales of your product if you prove that you can use this in pediatric populations safely. And it's, I don't know, you can take that for what it's worth as far as a business decision or if it's ethical or not. But the nice thing is we do have some pediatric data out there for some medications that otherwise you're kind of taking a shot in the dark whether it's actually going to be effective for the kid. You assume it will be, right? Why wouldn't it be? Kids are really just small adults. Not really, but they kind of are. I mean, the physiology is similar, so should be pretty much the same, right? But again, you don't know what people are going to respond to. So we talked about even like when we looked at ADD, right? You have kids' drugs like guanfacine that don't really work all that well in adults. So why is that? Well, there are differences, of course. So you have those types of things to consider. But sometimes it's trial and error too, and other times you're looking at really small case studies or case cohort, groups of small case reports that they've pulled together to figure out, does this work in pediatric populations? So the literature is not always solid, is my point there. Sometimes they do look at juvenile animal studies, so studies in developing dogs or monkeys or what have you, rabbits, rats, and they'll show you that they've at least proven safe and maybe somewhat effective for whatever they're trying to do. But again, that's not going to translate to human medicine all that well in all cases. And then there's, again, off-label use, safety reporting, and other things like that. So a lot of medications actually commonly are off-label. So for example, albuterol is not indicated for children under 4 technically, but of course we use it for kids all the time. So just don't take that with a grain of salt if you're reading it and says, for patients under or over 18 or patients over the age of 8, well, what if I want to use it in a 7-year-old? Well, probably can. All right, adherence issues. So, of course, most kids, especially little kids, aren't going to take meds by themselves, right? If I gave my toddler a medication schedule, he would stare at me. But you can, of course, help the parents out with this to help them with reminder strategy, especially if you give them like a QID antibiotic, maybe have them set a cell phone timer reminder or something like that if they aren't used to timing their own meds out. Children can be resistant, so we can flavor things. So a lot of things come in suspension form, and if they don't come in suspension form, most things can be compounded into suspension form from the existing tablet. You may have to go to every pharmacy technically should be able to do a compound. That's something that's law. So as a pharmacist going to pharmacy school, I took compounding, and I can theoretically compound things. Now, I worked in a specialty pharmacy for a little bit, so I'm actually pretty good at compounding. Not just to toot my own horn a little bit, but most people probably aren't, and some people might not. Some pharmacists may not be comfortable with it, so they may actually defer to like a pharmacy that might work specially with like children's or something like that, or like the U of M discharge pharmacy that discharges pediatric patients if it's a more advanced compound. But anyway, the recipes exist out there for a lot of products, and a lot of them have decent stability data to give them a couple months worth. So you can get somebody a month's supply of something. So a lot of times things that fall into this would be like anti-epileptic drugs, Crohn's medications I've done, all types of things like that. So you see differences in how it's supplied, and over time, like for example, Keppra comes as an oral solution. Most antidepressants come as oral solutions, and not only is it for pediatric use, but it's also helpful for adults who might be, NPO, or not NPO, but like on a feeding tube or something like that. So convenience, less frequent administration times are always good, just like with our adult medicine. And dosage forms work for the patient. Taste, if you've never tasted antibiotics, which, well, I don't know, maybe you have, maybe you remember, maybe you've had it recently, but I took a class where they actually let us taste a bunch of different ones, which is kind of interesting. And some of them taste really, really bad, and some actually taste pretty good. So generally speaking, in case you're wondering, penicillin, for example, which you use for strep throat, tastes terrible. Moxicillin tastes pretty good. So that's why we generally prefer giving people amoxicillin suspension as opposed to penicillin. Just, tidbit there. Ceftonir tastes really good. So that's a good third-gen cephalosporin to use. All right, anyway. So I want to talk about some medications that you should quote-unquote know. And we've already talked about this a little bit. Whoops, my recording thing got way off here. Hold on a second. I don't know what's going on. There we go. Sulfa drugs, so infants in less than 2 months, it's contraindicated to use. The exception being in HIV-positive infants who have pneumocystis pneumonia, which would be unusual, but it's possible. That would be an okay use because that's really the drug of choice. The reason why is something called kernicterus, which is staining and damage to the brain from excessive bilirubin levels circulating in the blood. So your neonates just can't process bilirubin as fast, especially if they're premature and their liver's not able to do it as much. And so what happens is, remember you have in neonatal kids less albumin circulating around. So bilirubin is highly protein bound. So is sulfobacterium in this case. Binds to the albumin, knocks off the bilirubin, you get higher blood concentrations of bilirubin, and therefore you end up with kernicterus risk. This can cause encephalopathy, which I listed some of the symptoms on there. So that's something, of course, we want to avoid. It's not a guarantee, and again, if you have to use the drug, you can use it. Just something we avoid in those first 2 months, just because there's usually better alternatives for most everything, or at least an equivalent alternative. Tetracyclines, we kind of talked about this already. If you remember back to the fall about the first 8 years of life with the teeth staining thing and how this is probably maybe not actually true based on some of the more recent studies that actually have shown this being used again for diseases that we really want to use doxycycline for. So like Lyme disease or babesiosis, or is that Rocky Mountain spotted fever? I can't remember what the actual one is. But anyway, doxy is a really good drug for that. And in the cases of that tends to be a pediatric illness. So we have to use it, and it's sort of a risk benefit. And again, studies looking at these kids that have gone through those courses haven't actually found that this happens. So maybe more theoretical than anything else. But it's still something we try and avoid if we can. Salicylates, we talked about this already a couple times. So avoid in all children and adolescents, with the exception of CV disease kids and low-dose antiplatelets. So sometimes patients with a CV malformation post-surgery, they might put them on antiplatelet therapy, or if they have other some sort of heart defect that's causing like a early heart failure, or pulmonary hypertension, or something like that. And the peds cardiologist deems that they need to be on this. There's some exceptions to that, but generally we avoid it. Ray's syndrome, again, very rare. There's a chart here, and this looks like I just made it up. I got it from somewhere reliable, but I can't remember where. But basically, the risk of Ray's syndrome goes down dramatically. It's associated with viral illness, likely, and salicylate consumption at the same time. Oh, this is just a funny thing. This is an old, I think this is a public health ad, and it's got a funny poem about Ray's syndrome. You can read it on your own if you want. It's kind of humorous. I won't read it right now. Fluoroquinolones, Cipro is probably the one you're going to think about a lot with kids as maybe an option for certain diseases that could be convenient. Levaquin, moxifloxacin, possibly for respiratory things as well. You'll see a lot of recommendations to avoid this. I've talked to some people that work at, when I did a rotation at Children's as a student, and I talked to some of their pharmacists, and they actually say that they do use fluoroquinolones from time to time. Not an absolute contraindication. It is, again, kind of like the rest of these, something we try and avoid if we can. So what exactly is the issue? Well, the joint tendon issues is something we talked about last fall. And they looked at beagles, and they gave them 100 mg per kg of Cipro daily for 4 weeks. That's a really big dose, in case you're wondering. So they overdosed beagles with fluoroquinolones, basically is what I'm saying. This caused degenerative changes in the knee joint, and they also showed minimal effects at 30 mg per kg. So for example, like, I don't know what the mg per kg dosing of Cipro is off the top of my head, but usually you're looking at like 1,000 milligrams of Cipro a day for an adult. So maybe like, what's that, 10 to 15 mg per kg, something like that. I don't know, do the math. What you'd get is, so anyway, what this is looking at is likely a pretty substantial overdose. And again, when you go down to 30 mg per kg, which even if we're assuming that's reasonable, which is still a little bit high, you don't really get a lot of effects for this. Levaquin and other fluoroquinolones shown to cause inflammatory arthritic lesions. Clinically, this just isn't all that common. There's a study looking at 6,000 fluoroquinolone-treated children compared with azithromycin and showed there's no difference in incidence. And azithromycin isn't associated with this, and we use it in kids. So the evidence is really poor to support this theory, and really we're going off an old animal study that was probably not applicable to human medicine in really any aspect. So it doesn't mean you can use fluoroquinolones whenever you want, but it does mean that you could in certain situations. So it's sounding very familiar. None of these are really absolute contraindications, right? But you can use them, you know, when clinically indicated. So like UTI could be a good use if you have a resistant pathogen or maybe a really strong you know, beta-lactam allergy that can't tolerate cephalosporins or penicillins. And then anthrax as well, which would, of course, be unusual. But, you know, if you had chemical attack, God forbid something like that actually happens, but if it did, Cipro's the drug of choice, and you want to make sure all your population's getting that as soon as possible. All right. Let me just adjust my screen. For some reason, my PowerPoint slides decided to shift over on me. There we go. All right, so neonatal disease basically is a bunch of different respiratory things. And there's not a ton of drugs, again. So I'm not really going to test you, well, I'm not going to test you at all on like the different development or necessarily the symptoms, but I do want you to know kind of which types of diseases and generally speaking what the common treatment we're going to use is. So this is just lung development. Basically the big marker here is the 24-week point. That's where your lungs are pretty much viable as far as being able to breathe on your own. A kid born in that time period is likely going to need a lot of support anyway, but at least the lungs have a fighting chance. So that's why that 24-week mark is really critical when we're talking about premature infants and premature births. Once you get to 26 to 36 weeks, you're slowly getting the true alveoli development, so that really finishes up at 32. Gas exchange is possible at that point, but not really optimal. And then continues to development after term delivery up until 6 months. So you've got a lot of work for your lungs to do until they're really fully at probably about 6 months of age at that point. So that's why respiratory diseases are so common in little ones. So respiratory distress syndrome is where I'll start. Basically, immature lungs have a decreased ability to produce pulmonary surfactant, which is something that everybody just produces normally. In these kids, they just don't have that piece built in yet. And so when we're looking at incidence, it's inversely proportional to your gestational age at birth. So 25% at 34 weeks versus almost 80% at 28 weeks. So you can see, again, that development is critical to preventing some of these things. So you get inflation of the lungs without surfactant that can damage, cause inflammation, and cause other types of complications, specifically putting these kids into like kind of a short acute pulmonary hypertension situation where they're getting a lot of pressure in the pulmonary artery, can possibly lead to fluid backup on the lungs, and even could potentially go into a heart failure type situation if it's not treated appropriately. Usually develops in the first 2 to 6 hours of delivery, so it's something that comes upon quite quickly with tachypnea, retractions, grunting, cyanotic appearance. Prevention, usually you can, if you can delay delivery, of course, you want to do that. Try and give your drugs to prevent that if you can, or if you have to go with delivery, you can give some steroids during the birthing process. So dexamethasone and betamethasone are popular choices, so high potency steroids. This can promote lung cell proliferation, and anybody who's giving birth less than 35 weeks is going to get this prophylactically. We use betamethasone a lot, which is we don't use betamethasone outside of OB very often at all. It's a very potent steroid. You probably remember it maybe from the derm stuff. It's one of the highest potency derm ones. It is useful for this. You can only give it really IM, so it doesn't come as an oral product that I know of, and you can't give it IV. So that's why we like dexamethasone pretty much in all of our other situations. It's a little bit easier to use from a delivery point of view, but they do like betamethasone. And again, OB is kind of odd in the sense that they have literature supporting very specific drugs, and that's what they go with, even though, not to say betamethasone's better than dexamethasone, they're essentially the same thing, but anyway, that's what they use. Anyway, so treatment surfactants are available. They're synthetic and natural. They're quite expensive, and there's not really a clear difference that exists with each product. And I don't know if there's really, you'd have to work in pediatrics more so, or neonatal medicine to really understand these, I think. So I'm not really too, concerned that like different surfactants, other than that surfactants exist as like a drug. So basically you can give inhaled surfactants. You're going to basically nebulize them into the lungs with a respirator or whatever, however you have the child hooked up to breathing support. So remember, we have a pulmonary hypertension, possibly fluid situation going on, so acute edema, specifically pulmonary edema. You can give diuretics, you can give Lasix to children. It works just as well as it does with adults. With premature kidneys, that's a question mark. Is it going to push the urine through enough? And that's something that you just have to experiment with, I think, in a lot of cases. And then we use a lot of nitric oxide in kids. It's a pulmonary vasodilator. You get it right to the lungs. Doesn't have a whole lot of side effects associated with it. It's expensive. It's a gas, inhaled gas, but it does work quite well for this. We use it for adult medicine too, for acute pulmonary hypertension occasionally as well. All right, chronic lung disease. So definition is this oxygen requirement at 36 weeks gestation. So this is sort of a continuation of RDS, if you want to think about it like that. The oxygen requirement and abnormal chest X-ray at greater than 28 days of life would be something that is considered chronic lung disease. So basically you've had some sort of maybe a premature birth, premature kids, low birth weight, much higher association of this. It's some sort of a continuation of those acute instances that happened right after birth. RDS symptoms are going to be basically continued, so you're really going to see some continuation of this. Congenital heart defects, intubation, early intubation can cause some pulmonary damage as well. Infectious diseases like a pulmonary pneumonia would be possible risk for chronic lung disease as well. Prevention, vitamin A. So premature neonates have really low blood concentration, so this is something we can give to improve that. Fluid restriction, and we want to provide adequate nutrition, but we don't want fluid backing up, getting worsening edema, and surfactants work as well. So again, nutrition, diuretics. You can use both loop and thiazide diuretics, are both acceptable. You can use them together just like we would in adult medicine, so not really any different there. Bronchodilators are available too, so albuterol and ipratropium. Again, medications we use in adults, so there's not a whole lot of differences with any of this stuff we're talking about. Glucocorticoids can be reserved for severe cases. They may impair or stunt growth in more sustained amounts, but in the case of a child that maybe has a severe case going on, you can use a short burst of them. You can also give inhaled budesonide, which would give the steroid directly to the lungs, which could be a good option for a lot of kiddos. Apnea prematurity is a little bit different. So the definition is that you have a pause in breathing for 20 seconds or for 10 seconds with with some sort of bradycardia on board too, and a drop in O2 sats at the same time. This is associated with low birth weight and premature gestational age. Again, no surprise there. And causes are pretty similar to chronic lung disease. So this could be, again, infectious disease, heart defects, or intubation, probably the three main causes. Mechanism, so you've got a number of things listed there that could be possibly causing the decrease in pulmonary response, but it could be really any of those things. This has a unique medication, sort of. Methylxanthines we use for this, and you first want to treat the underlying cause like you would with anything. So if it's CV disease or an ID, you want to make sure you're treating that. But we can give methylxanthines for support. So proposed what we think methylxanthines do is have some sort of activity on the adenosine receptor as an antagonist, and have antagonist effects on GABA neurons central. So the GABA neurons, by antagonizing them centrally, should have some sort of anti-inhibitory effects in the central nervous system, and the adenosine should cause some sort of respiratory prevention of respiratory depression. Again, it's a little bit conflicting as to how exactly they work, but that's sort of the theory. Mostly it's thought to be central active. So aminophylline and caffeine are the two drugs here. We talked a little bit about aminophylline during respiratory. It's not a commonly used medication in adults. It's available IV and PO. Caffeine is much more preferred. Generally, it has a wider therapeutic index, less frequent dosing, and much less tachycardia associated with it, which aminophylline has more. It's also aminophylline shorter acting. However, aminophylline is really cheap. Caffeine at one point was almost impossible to get IV caffeine. It comes and goes. It's a drug shortage thing that's been on and off forever. In fact, interestingly enough, if you follow politics at all, and I only know this because I'm a pharmacist, and she spoke at my graduation ceremony about this, but Amy Klobuchar was actually contacted by a pharmacist at Children's Hospital about the caffeine drug shortage, and he presented her with a bunch of evidence and review, and she's been a big crusader nationally for getting drug companies to help end some of these shortage situations. So again, political views aside, sort of an interesting Minnesota tie there. And that guy was a former preceptor of mine, so kudos to him, I guess. All right, good. So caffeine, you guys don't need to know the side effects of caffeine, right? You probably all got that down. But it is something we can give, and of course we're giving it intravenously, and so it's not like they're giving it oral or anything like that. You probably could if the GI tract was good. You might be able to absorb enough orally if you did it, but generally we're giving it IV. All right, so infectious disease, you thought you didn't have to come back to this, but now you know you do. So we talked about a little bit of ID in OB, and now we're going to talk about it much more. So you just can't get by, and we're going to come back to it a little bit in emergency medicine and critical care as well. So here we go. Kids are susceptible to infections. Fortunately, a lot of the drugs we're using for kids kind of in the broad spectrum category, and we're going to approach it pretty aggressively for the most part. Unless you, again, have cultures just like you would for an adult and you can narrow appropriately, it's not really going to change your plan initially. You're still going to treat broad. So this just goes through some of the different immune system things like natural killer cells, fully functional a little bit later in life. It takes your body a bit of time, of course, to build an immune system up, and so you have a number of concerns. Nosocomial bacteremias, Group B strep, biggest ones right there. And then that can lead to meningitis situations. Fungal infections are less common. And then, of course, if you have somebody who has previous exposure, apparent HSV, HIV, there's the risk of vertical transmission there. Or is that horizontal transmission? Vertical, thank you. Yes, vertical, that makes sense. All right, so nosocomial bacteremia, let's start here. So this is just a premature infant risk situation, and usually the longer a kid's in the hospital, the increase the risk. Just like with adults, the longer you're in the hospital, the longer you're exposed to possibly getting some sort of nosocomial infection. Common bugs, Group B strep, again, biggest culprit here. E. coli, enterococcus, listeria, H. flu, and Staph aureus, even more rare. So these are the things that you're probably going to see. A lot of them are enteric pathogens, so you might see that coming from various contaminated sources. Maybe there is, like a UTI that gets involved at the same time due to stool getting in the urethra. It's possible that could lead to, more of a systemic infection as well in kids. So there's a number of things that might make sense that way. And also you don't have common immunizations as well, so you can think about that with these little kids as well. Treatment, ampicillin, gentamicin, or vancomycin. It's really going to depend on whether or not Staph aureus is involved. So for all these things, we're usually going to target with gentamicin and ampicillin. Ampicillin covers listeria really well, and it also covers most strains of enterococcus. And gent takes care of all the gram-negative stuff. Ampicillin also covers group B strep really well. If you had Staph aureus growing out on a gram stain or any type of staph, you'd probably start vanco empirically. Make sure it's not MRSA. The problem with bacteremia is it can really mimic a lot of other IDs, so that's why a lot of these things are going to sound the same. So bacteremia is a good place to start because this is kind of your building block and foundation for acute pediatric infectious disease. All right, group B strep infection. So this is one of the reasons we're so aggressive with treating mothers who are group B strep positive. We want to make sure we're avoiding that transmission. Prematurity, male sex, and multiple births all increase the risk for the child of getting a group B strep infection, in case you're wondering. And group B strep can go on to not only cause bacteremia, but can also cause meningitis, cause skin and soft tissue things, and pneumonia, which can all be really detrimental to a developing child, especially when they're really young. Treatment, penicillin, basic penicillin works really great against group B strep. There's no reason why you need to expand beyond that if you know it's group B strep. But we use ampicillin a lot because it's a bit more convenient as far as the dosage forms it comes in, and it's a little bit easier for us to stock and administer it. Penicillin's kind of weird. We have to compound it in our IV room. Ampicillin, you can just buy it in vials and hook it up when you give it. It's a little bit easier. If somebody is penallergic, clindamycin is an alternative that covers group B strep really well. It's probably the primary one we're going to be using. So, again, very similar, if not identical, to how we treat an adult. Meningitis can come from group B strep. That's about 50% of the incidence. You can also get it from E. coli as well, or listeria. So we're looking at pretty similar recommendations here, with ampicillin and gentamicin being a common one. An alternative to gentamicin, if you don't want to do an aminoglycoside, cefotaxime is a popular choice. So you can think of cefotaxime kind of like the pediatric version of ceftriaxone. You can use ceftriaxone in kids, but in really young kids, it does have a risk of developing it has a connectorous risk, but it's different. It can cause a biliary sludge so that you just aren't releasing bilirubin into the GI tract like you normally would, and so you can accumulate it in the bloodstream. So it does have that risk. We usually use cefotax in the really young kids, but pretty much the exact same coverage. Think about it kind of as your alternative to ceftriaxone. If staph, again, you can use vanco, and you've got about 2 to 3 weeks of treatment. You'll notice we aren't really using drugs like cefepime or zosyn. You certainly can in kids, but usually we aren't seeing bugs like that. We aren't seeing Pseudomonas in children. We aren't seeing those really weird gram-negative infections. Not to say it's impossible. If the child was immunocompromised, you very well might, but in the same time, we're wanting to focus on the bugs we know that very high incidence of. Fungal infections are very unusual. You can give prophylaxis in some cases. Fluconazole maybe for most patients. It's probably going to be Candida if anything, if you're going to get it, but it's very uncommon, just like it is with adults. Not a really common situation unless they're immunocompromised. HSV is possible, especially if the mother has an active lesion during the birth. You can have a C-section, which can decrease the risk of transmission potentially. But it can affect immunocompromised patients regardless of their history of the parent. So you might get local central nervous system. If they do get some sort of like viral meningitis type of a picture, you can give acyclovir, just like you would adults, same thing. And then we can give, just a reminder, I think this was covered briefly during George's lecture, but zidovudine is an IV HIV medication that's given to kids in the peripartum period that can help with decrease vertical transmissions. In fact, it's very effective at doing that. So the mom's usually on quite a few drugs too to prevent that, to suppress that viral load as much as possible. And then IV zidovudine can help prevent it in kids. All right. So ID, yeah.
Was that medication given to the baby or
yes.
before?
I don't know if they give zidovudine to the parent. It's a good question. I think they usually try and give orals to suppress it, like Truvada or some of the more common oral medications. Oh, yeah, maybe it must be. Maybe they're trying to get it across the placenta. Yeah, you're probably right there. Yeah, I'd have to double check and see exactly what the protocol is for that, but yeah. Just know that it's to prevent. It's the only HIV med that's IV, so it's the only one we can use for kids really in that postpartum period initially.
To prevent them from getting it.
Right.
Or
and afterwards too, you want to continue it because they did get some exposure. You want to make sure that the virus can't really do anything in that period of time. It's kind of like the pre-exposure, post-exposure prophylaxis strategy. You give them antiretroviral drugs to stop doing that, and that's what the zidovudine can help with in the postpartum period. Okay, any questions on ID stuff, treatments? Basically, you're looking at ampicillin, gentamicin, and then that cefotaxime maybe as an alternate for gentamicin. Cover your gram-negatives. Okay, PDA or patent ductus arteriosus. So the ductus arteriosus, it sounds like you guys talked about this a little bit already, but your communication between your aorta and your pulmonary artery should seal up and close off. What can happen is if you get a patent DA, you might get poorly oxygenated blood. It's not usually something that's fatal, and it's something that can be corrected. And usually they close on their own sometimes, especially if you have a premature kid, they might close on their own. But it can cause heart failure, hypertension, possibly even arrhythmias too. So we want to make sure we're addressing it. And again, small ones can be totally asymptomatic. You might not even know they have it because it's going to close up pretty soon after birth. Treatment, we give NSAIDs for this. So ibuprofen and indomethacin can keep can help close that. The reason is because circulating prostaglandins keep the ductus arteriosus patent. So if we can shut down prostaglandin production a little bit, we can help close that off easier. So think about this again, prostaglandins vasodilating, so you're decreasing that natural vasodilating mechanism. This is only really helpful for preterm kids. If somebody goes full term and they have a big patent ductus arteriosus, probably going to have to surgically correct it or use a catheterization procedure that way. Necrotizing enterocolitis is something that can happen with inflammation of the intestine or colon, and usually you're looking at a perforated bowel and can cause ischemia. Premature infants at highest risk for this, and you're looking at a really nasty intra-abdominal infection potentially. So we're talking about drugs like Zosyn and Primaxin or cefepime and metronidazole. So we want really broad spectrum gram-negative coverage and anaerobic coverage to get those GI bugs. And then the treatment after that is pretty much just supportive care, surgery if needed, whatever else you might need. But I just wanted to throw this in there. It is something that happens in more acute care medicine with kids, so just something to know. Okay, so that's sort of the neonatal side of things. Of course, we just talked about a lot of acute care, which is what you're going to be seeing with neonates. So we treat our neonates very seriously, of course. They're very fragile. They need to be aggressively managed. And now we're going to move into maybe some of the more, I guess, not necessarily softer stuff, but stuff that you could maybe manage as more of an outpatient/inpatient. Okay, so Croup. Croup is a disease that affects the area just below the larynx, and usually it's viral, so we're looking at parainfluenza and RSV, or respiratory syncytial virus, adenoviruses, and measles in the current situation, well, actually the measles outbreak is sort of tapering off, hopefully, but hasn't quite finished completely. But mid-autumn and odd years is usually when you see, interestingly, I don't know why, but cases of croup come up, so they think that there's some sort of cyclical nature to parainfluenza virus. Why, again, I don't know. Children 7 months to 3 years are usually the common culprit. Usually after 6 years, you probably aren't going to see croup in a kid. It's really unusual. Barking, cough, inspiratory stridor, and hoarseness are the common things you see with croup. You'll hear the term croupy cough. You can Google it if you want to hear what it looks like or hear what it sounds like. There's a lot of examples of it on YouTube. Treatment, fluids, acetaminophen for fever. Cold humidifier can help, and if they're exposed to tobacco smoke in the home, getting them out of that or preventing that can help a lot, which can be a lot easier said than done. We give dexamethasone. This is an interesting mg per kg dose because you end up really giving kids high doses. Like I've given a kid 20 milligrams of dexamethasone. Usually when we're treating adults for a burst of steroids, you're giving them 10 max. So so don't be too alarmed if you have a larger kid and you feel like you're hammering them with a lot of dexamethasone. It's a big dose, and that's okay. There's a lot of studies that support that it's pretty safe, especially it's just a one-time thing. Just a tip, if you're prescribing this product, there's a couple different ones out there. So there's a concentration that comes as 1 mg per mil that has a lot of alcohol in it, and apparently it tastes terrible. I've had a lot of people say that their kids won't drink it at all. What we do to cheat is we take the IV product and we draw it up, which is a really small volume, and we shoot it into like some orange juice or apple juice, and we just have the kid drink the whole thing. The only thing you have to do is make sure that they're actually consuming the whole amount of liquid you're putting it into. But it dilutes it out enough where they can't really taste the medicine, so that can be a way to get it into the kid. Or you could give it IV if you just really want to do that. Or IM works too, so there's that. We use also racemic epinephrine nebulizers, and that helps with some local vasoconstriction, especially in the throat area. So it doesn't really get too far into the lungs and affect that a lot, but it does help in the upper respiratory tract with that. Bronchiolitis is a lower respiratory tract infection, and this is usually an RSV-related disease. So RSV can cause a croup-like presentation, but it can also cause lower respiratory as well. Usually children less than 2 years, and usually you're seeing in the winter to early spring months. It's the #1 reason for infant hospitalization in the United States, and the presentation is listed there. So usually kind of a nondescript presentation, some hemodynamic things, fever, of course respiratory symptoms as well. Treatment is mostly supportive care. Remember, this is viral, so antibiotics aren't going to do any good. You can give the racemic epinephrine if they're having some upper respiratory symptoms as well. Maybe they have a croupy cough in addition to some lower symptoms. Hypertonic saline nebs can help too with some of the secretions, and we'll talk about those a little bit more when we talk about very briefly about cystic fibrosis later today. And ribavirin nebs are an antiviral nebulizer treatment that you could possibly use in really severe cases, but the data is mixed, and we wouldn't use it unless the child was, almost at death's door because of this. There is a prevention medication called palivizumab or Synagis, which is a immune globulin that you can give during the RSV season if they're really high risk. So if they're less than 6 months old and they're premature, kids might get treated with this during that season. Or, maybe they've had a history of it or something, and who knows, or they have some sort of a pulmonary anatomy malformation or something, but it's really expensive, so you want to use it carefully, but it can be used. All right, pertussis is whooping cough, or otherwise known as whooping cough, and Bordetella pertussis is the bacteria that causes it. It's less than 6 month old, primarily as your patient population, and or if they're older than 6 months, non-vaccinated. So most kids by the 6 month mark should have their full vaccine series, and they should at that point not really be prone to this anymore. So occasionally we see this breakout in adults too, because the immunity does wane, and it's usually not infected. Like we actually had a number of doctors and nurses in our emergency department a few years ago exposed to this and had to go out because they all had pertussis. And it's because if you're getting continual booster shots of tetanus and diphtheria, you aren't getting the pertussis component, and that immunity can wane over 20, 30 years after not having it. So you get upper respiratory tract symptoms, cough, stridor, usually no fever. You might get some apnea and could possibly lead to comorbid pneumonia, but that's rare. Treatment is azithromycin or Bactrim if you're over 2 months. It's not really effective after the cough is established, so this is something to tell the parents on. If they come in with a whooping cough, you can treat them with antibiotics, and it can help prevent the spread of it, which is nice for the other family members who don't have it. But if everybody in the house is vaccinated and they're out of school or whatever, or out of daycare for whatever reason because they're sick, it might not be worth the antibiotic exposure. It's probably not going to help all that much. So sort of we got to look at each case as an individual situation and decide what's best for the patient. Pneumonia can have a really similar appearance to bronchiolitis, so you have to differentiate viral versus bacterial, which is the same thing with adults. There's a pretty high incidence of pediatric death associated with pneumonia, not only in this country, but worldwide. So we have a number of vaccines that hopefully prevent a number of causes. So pneumococcal, H. influenzae type B, and influenza virus can hopefully all prevent some of the more common causes of pneumonia. But there are other bugs like Group E strep for newborns, potential with exposure. E. coli and listeria can all cause pneumonias in kids. Then you have atypical infections, which also affect children, and viral infections too. So We all know that the influenza vaccine isn't 100% effective ever, or no vaccine is, but usually on a good year you might get 60 to 70% efficacy, so that's always a risk, even if you're vaccinated. So we want to make sure we're using our common sense when narrowing possible infectious source. So was it from daycare, hospital, travel? That can help decide your treatment strategy here. If everybody at daycare, if somebody at daycare had a positive influenza, maybe that's what it is, but it shouldn't necessarily be the end-all be-all. So for kids birth to 30 days, you're looking at maybe viral things like HSV exposure, cytomegalovirus, and these are going to be kids who are probably immunocompromised that fall into that category. And then over 1 year old, influenza is going to be likely the most common culprit for viral infections. And Tamiflu, like we use for adults, is approved in kids over 1 year old. And they actually use it in kids younger than that too. It's just not technically approved. What else? So then we get to bacterial. So this is going to sound hopefully a little bit familiar. So in a young kid, we're looking at, again, AMP plus Gent or maybe cefotaxime. 1 to 3 months old, you're looking at outpatient treatment being okay in some cases. So you could treat with amoxicillin, high dose, or azithromycin. Either one is probably okay. I probably prefer amoxicillin. It's more likely, I think, to be strep-related than atypical, but it's a bit of a toss-up. Both have decent evidence. So notice this is much different than adults. Hopefully you remember the adults we treat pretty aggressively when I cover atypicals and our strep pneumo in most patients. In this case, you can, just because of what affects these kids, they don't have a lot of issues with necessarily other types of bugs that are going to be problematic for these drugs to cover, so it's usually okay. 4 months to 5 years old, often viral, but you can do amoxicillin plus maybe ceftriaxone IM. And then sometimes you can use augmentin if you want to, or azithromycin. So there's a couple other options. It's pretty much the same set of stuff, but you can get a little bit more broad spectrum with the augmentin or the ceftriaxone. And then over 5 years, you're looking at kind of a similar treatment strategy to adults. So amoxicillin plus azithromycin, levofloxacin plus moxifloxacin. If somebody's not responding to amoxicillin in any of these categories, you can advance them to a more advanced generation cephalosporin like Ceftonir. And then, or add-ons with azithromycin if you think it might be an atypical presentation. But fluoroquinolones are okay for the over 5 year group, generally speaking. Again, there's that tendon rupture thing, but we talked about that. All right. Meningococcal disease, Neisseria has about a 10% fatality rate, and about 18% of adults can be colonized but not have any infectious disease presentation with it. There's a ton of pediatric-specific diagnostic criteria, but basically, if you're suspecting it, you're going to start antibiotic stat, you're going to treat with broad-spectrum vancomycin plus a third-generation cephalosporin. That's really the same treatment as kind of the core meningitis treatment for adults, vanco plus ceftriaxone, or in little kids, you'd use cefotaxime. Carbapenems and fluoroquinolones can be an alternate depending on allergies or response, but those are going to be the core ones you're going to use. And then you get the vaccine age for meningococcal is 11 to 12. So this is usually an older child disease, and we associate it also with young adults at college as well. But it can affect kids younger than that. All right, UTIs very commonly affect girls. Pretty rare overall in boys. It is about 8 to 9 times higher rate in uncircumcised boys, but it's still quite low compared to the general, overall incidence. So it's not like it's a reason necessarily. The pediatric or American Academy of Pediatrics doesn't say it's a reason to routinely circumcise all kids. Untreated can lead to serious kidney damage. So kids are pretty susceptible to UTIs, whereas an adult it might be painful, uncomfortable, but usually it'll clear over time. Kids can actually, with developing kidneys, get pretty severe lasting damage. Bugs are pretty much the same, looking at E. coli for the most part. Enterococcus can be more common, specifically due to dirty diapers and exposure to that area. And Pseudomonas would be a rare source, but it is seen in kids occasionally, so it's something to consider. Kids under 2 will have a really specific non-presentation. They aren't going to tell you they have dysuria, right? They might just be crabby and cranky. The treatment, if less than 3 months old, they're usually admitted to some pediatric hospital for IV therapy. Over 3 months, usually PO is okay at that time, and usually treating pretty aggressively, so usually going straight to a third-generation cephalosporin, specifically Ceftonir is a good one to use. Augmentin is also good, has good coverage against most things as well. It's kind of interesting because Augmentin's kind of a preferred one, but its E. coli coverage is weak in the community. With kids, you always wonder if they're getting exposed to more aggressive pathogen or not. But I would probably stick to cephalosporin if it was my kid, just because of the Augmentin coverage and amoxicillin coverage of E. coli is not good in the community. So you could use cephalexin too. That'd be a good alternative. If you read a lot of the recommendations, they'll tell you to use a third-generation cephalosporin. There's no real rationale for that. It's all about coverage, and cephalexin covers E. coli great. Bactrim works in those kids over 2 months as well. We talked about Bactrim having weak coverage, but it is an option you could use. Then, of course, fluoroquinolones might be a backup in case you get a weird situation, or specifically Pseudomonas, you'd have to use a fluoroquinolone, or you'd have to admit them for IV antibiotics. For hemolytic uremic syndrome, it's the most common cause of acute renal failure in kids under 10 years. Not a common thing to happen, but it is something dangerous and we want to watch out for. So Shiga or Shiga-like toxin-producing bacteria associated with food poisoning outbreaks, so E. coli that is going to be enterohemorrhagic, and Shigella and Salmonella can possibly cause this as well. These aren't normal flora. They're usually from contaminated animal products. You can do a stool sample to test for them. If you get it infected, if a kid gets infected, it's about a 15% risk of actually getting this syndrome, which is pretty high compared to adults. Most kids will resolve spontaneously, but for those 15%, they could go into kidney failure. So the problem is you get these toxins into systemic circulation, you get into the kidneys, and then you get kidney damage. And so you can get an inflammatory response, and treatment is really just supportive. So when you're looking at treating these kids, it's fluids, electrolytes. You might need to dialyze them. You can dialyze off a lot of these toxins in some cases. You don't want to give antibiotics because just like with adults, you lyse those bacteria, you increase your problem exponentially. So be careful with that. But otherwise, it's supportive. All right, let's talk about vaccines really quick, and then we'll take a break. I don't have a lot to say on vaccines, so I'm not going to make you memorize vaccines other than just knowing which ones are alive. I think that's an important one to know, and there's not a lot of them, so it's, I think, pretty easy. Okay, so vaccines, what are we trying to do? Stimulate our immune system to respond to specific antigens. Vaccines are designed to be antigenic but not pathogenic, meaning they want to react to the immune system, but they don't want to give you a disease. Goal is to develop antibodies against specific infectious pathogens without causing harm to your patient. And most people say that vaccines are the widest success in public health world since clean water. Like, those are the two big things that prevent the majority of disease in developing nations and worldwide. Oh, and the CDC, the end-all be-all for everything vaccine-related. It has tons of interesting stuff. So, if you're dealing with people who are anti-vax and their mentality, you can go to the CDC to build your argument. I would never, ever recommend referring them to the CDC because somebody who's anti-vax probably thinks the CDC is like a government conspiracy. But it's got a ton of good stuff, and it'll explain, like, hey, if you Google thimerosal or, does MMR cause autism or something like that, the CDC will pop up and it'll go through all the information as to why people think that. It's got a lot of good stuff, and it links a lot of articles and studies on it too. So if you're interested in more, I'll talk a little bit about some of the common myths here in a second, but that's a good resource for pretty much everything. That's where I pretty much got all of my information. So attenuated live vaccines are designed, they're treated to alter the pathogen specifically. They can't induce a full-blown disease, but they might cause a more mild variation of the disease. So that's where live vaccines are tricky with pregnant patients, immunocompromised, and very young children, because they're much more susceptible to those effects from it, and they could actually get closer to a version of a full-blown disease from the actual live vaccine. Inactivated, we killed the organism with a heater chemical, so it has some sort of particle that the body can react to, but it's just not going to do anything. Toxoids are specifically designed around bacterial endotoxins, so like strep or pneumococcal. Might be, and then, or like a polysaccharide or polypeptide, where you have cellular fractions of the organism, so like a bacterial cell wall, a viral capsule. And then surface antigens would be a recombinant thing, where like Hep B would be an example of this, where you have the specific surface antigen present on the virus that's just present in the vaccine that can react with the immune system. So there's a number of different ways we can do this, and I'm not, other than live vaccines, I don't want you to know any of that. It's just for your information. This is the vaccine schedule, which also you don't need to know anything about. It's something that you can look at on the CDC website whenever you need to. It's super easy to find, so there you have it. It should be at your fingertips at pretty much all times. And it's just, there's a lot of vaccines out there, so it's really hard to remember what goes where. And I wouldn't ever expect anybody to memorize it all, unless maybe you work in pediatrics and it's something you want to pride yourself on, knowing the entire vaccine schedule. Go for it, but I can't even keep it straight. This one I put up here. This is also on the CDC. I took it from Up to Date, but it's on the CDC, and this shows you some different indications for specific vaccines. So this is a question I get a lot. Like, what if somebody is, what if they have, what if you're pregnant? Can you get the flu shot? Yes, you can. Sure. So you can see some things like this, like if it's contraindicated in pregnancy, or if you have HIV, is it contraindicated? There's a lot of misconceptions out there about who can get vaccines, and this is a good one to show you some specific areas. Remember, it's the live vaccines that are the biggest issues for those select groups of populations, and that's really it. Otherwise, we can give a lot of vaccines to most everybody. And so this is what I might ask a quick test question about. Which one is a live vaccine? Intranasal influenza, the flu mist, is a live product. The other flu shots are not. That's an important one to remember. So if you have somebody who's really afraid of shots, but they're pregnant, sorry, you have to get a shot. Zostavax is the brand name of that one. MMR is a live vaccine, and varicella is a live vaccine too.
live?
Nope. So there's a couple other live ones that are used in other countries, but Hep A and B are surface antigen ones. They aren't live.
Are they contraindicated in pregnancy? Because one of the slides said, like, shouldn't be giving Hep B.
I don't know. I didn't know they were contraindicated. What does the slide say? Pregnancy, Hep B. Recommended if some other risk factor is present. There you go. They aren't live, so I don't know why they'd be contraindicated. I don't want to tell you the wrong thing, but as far as I know, if you had a risk of exposure or something, you'd probably want to give it. Okay. All right, so what are actual vaccine contraindications or problems? Anaphylaxis. This is totally unpredictable. It's really rare, but if somebody knows they have a component allergy, for example, egg allergy being the biggest culprit, right, for the flu vaccine specifically, some of them use some egg-related proteins and products for incubation and how they replicate the virus using PCR or the product using whatever technique they're using. So in this case, if again, you could avoid it. There are some egg-free products that are out there on the market. Immunodeficiency in pregnancy, we talked about that. Immunosuppressive therapy is short-term. Hold off on vaccines until after, if you can, after they complete like a course of chemotherapy or they aren't immunocompromised anymore. Response is noted as good, generally speaking. So, or it's not as good. Sorry. So I should say not as good. That makes sense, right? If your immune system's already suppressed, you can't react properly to the immune. It's not like the vaccine's going to hurt you. Like if you gave somebody an inactivated vaccine and they're immunocompromised, you aren't going to get any really side effects or problems with it. You just aren't going to get a good response from it. So it's really about efficacy in that standpoint. Acute illness. Fever can mask allergic reaction symptoms. So that's one thing why they say if you're feeling ill or you have a temperature, don't get the shot. Now, there's plenty of other things that anaphylaxis presents as, so it's kind of, I don't know, whatever. But the whole thing is that the immune system's already ramped up, and you could get a potential attack on one of the particles designed to build immunity. Therefore, overall, it's kind of like your immune system might overreact and not really get as good of a natural response to it like you want it to. So there's a possible issue there.
Yeah, when you tell someone to come back and get their vaccine,
like if they're acutely ill.
like high-grade fever.
Yeah, I would tell them to to wait until their normal temperature. I don't know, maybe under like 100.4 or yeah.
I feel like I've gone in with like a cold and like,
yeah, I think if you have like a minor like cold and you aren't really symptomatic, it's just congestion, I would get it personally. But yeah, it's somebody asks you, because I think they ask you pretty specific questions. Oh. But yeah, I know plenty of people that have done it. Just remember the flu season's really long, and so you could always wait like a week and get it. You're probably still fine. But if you're seeing patients in a hospital, yeah, it might be better to get it right away. So. All right, so pointing out the obvious here. Hopefully everyone in this room is on board with my pro-vaccine platform here, but there is absolutely no link to autism whatsoever. So if you're wondering why, and if you've ever read about this, I think it's actually kind of an interesting story. So this started pretty much in 1998 was the first big scare. And this guy named Dr. Andrew Wakefield, who's a terrible human being, published a paper in the Lancet. Hopefully he doesn't ever see my YouTube video. I don't think he cares about me, but we'll see. So what he did was he published a study with a sample size of 12 kids that showed the MMR vaccine could damage brain tissue. Really tiny study, really obscure result, right? It wasn't even like it causes autism. The Lancet ended up retracting the paper, and Dr. Wakefield ended up getting stripped of his medical license in the UK because he falsified data and he couldn't replicate it into results. So you're wondering why he might have done that. Well, there's an investigative report, I think in the New York Times a few years ago, that looked into this more, and they found, now this is not necessarily pure science here, but they found that there was some likely financial conflict of interest where Wakefield had an investment in a company that was making a MMR vaccine that was a competitor to the current one that was out. So that's likely the reason why they were doing this. So why else would somebody do this? It just doesn't make sense. So there had to be something else at play here. No epidemiological comparisons or studies to back up any of these claims, ever. Yes?
Why did his study get published in the first place?
I think it looked good when it came out, and they're like, wow, this is really interesting. That's the only thing I can think of. That's a great question. It kind of makes you lose some faith in peer-reviewed medicine, right? Why would you publish a study about 12 kids? And yeah, I don't know. It's very strange. But anyway, this has fueled a huge chain reaction. You know, there's celebrities like Jenny McCarthy who have taken up this in, like, I think, you know, who else? I don't know. There's plenty of them out there. There's some celebrities that are pro-vaccine, so there's the other side of it too. But interestingly enough, again, the moral of the story is there's nothing that backs this up. Thimerosal is sort of the other arm of this. Thimerosal has nothing to do with MMR because it's never been in any MMR vaccine. So there's no mercury in MMR vaccines. In fact, there's no mercury in really any vaccines out there. The only ones that really have them still are some of the ones that are come from multi-dose vials. So, for example, some places will use the influenza vaccine that come as a 10-dose vial. That does have thimerosal in it. Like at the hospital, we use the individual shots. So they don't have any preservative in it. And that's exactly what thimerosal is, it's preservative. So that's the one thing you might see as an issue. Anyway, it's a mercury-based preservative. A lot of studies have proven there's no link between this and autism. Because a lot of people, the problem with autism is there's no answer for it. And I understand that if you have an autistic kid, you want to find a cause and maybe a treatment. And maybe if you can link it to vaccines, you can help people. So I get that there may be some altruism there. However, at the same time, I think there's been a lot of damage and a lot of people looking, you know, kind of on wild goose chases for some link that just isn't there. So I think it's time to give this up and move on. But some people will never do that. So you can only help as much as you can, I think. And anyway, thimerosal is virtually not involved in vaccines. We could talk more about thimerosal, but I don't think there's any point because it's really not a huge exposure at all. Other public concerns, what about vaccine overload? In fact, a lot of Republican politicians said stuff about vaccine overload during some debates this year, much to my dismay. And let's not get too political here, but I was concerned at some of their medical backgrounds and the things they were saying because it's just wrong. So the immune system, the concern is that if you overload the immune system, it becomes weakened and overwhelmed. Well, okay, so if you give a lot of vaccines in a short period of time, you increase the risk of anaphylaxis too. This is the main argument for a guy named Robert Sears. He wrote a book, and I don't even remember the name of it, but it's kind of a popular book that people like to cite when they talk about this overwhelmed, you know, immune system response. And if we're giving our kids a lot of vaccines, we're going to increase the risk of anaphylaxis. That hasn't been proven. There's no evidence to back up that you increase risk of anaphylaxis at all. And in fact, he's trying to fix a problem that doesn't really exist, which really bugs me. It's like there isn't an issue with this, and he's trying to delay vaccine schedules. So let's say you delay an infant's H influenza vaccine by a month. Okay, that's another month that they could get a deadly meningitis. And that was one of the biggest causes of infantile meningitis and one of the biggest killers of children for years and years until we vaccinated our population. So a lot of this is extremely dangerous, and I highly recommend not deviating from the CDC case. There's also sites, I've read things that, like, you know, people will say, well, the CDC settled with a girl who got encephalopathy worsening, you know, following multiple vaccines. And that's probably a fluke. You know, it happened. It was immune-related, possibly. We don't really know. It's definitely not the course. So the CDC does have a program called the Vaccine Injury Compensation Program. It's listed there. And so if you do get some sort of damage from vaccine or some sort of issue, you can report it to the CDC. They can review your case. But overall, very, very low risk or very low amounts of, you know, compensation coming out of that program. So I just want to point out that if you think about like an infant immune system and what you're being exposed to, it's incredible. So you're getting the entire world exposed to you at a time. So you're reacting to lots of different things, environmental exposures and possible threats. The immune system's built to react to tons of things simultaneously, and we don't even know the true extent of how fast it can react. The point is, you could probably give a kid a whole bunch of vaccines at once and be fine. But again, we do want to spread it out because A, you don't have enough muscles and are going to stick your kid with 20 shots in one visit and make them scream to death. Probably not. And B, we do want to give the immune system, in case there is some sort of delayed response, or the immune system can only take so much. We want to give it time to make sure it's building up appropriate response. So spreading out the vaccine schedule just doesn't make any sense really in any way. Although if I had the choice between somebody who wanted to spread out versus not vaccinating, I would tell them to spread out. I just personally wouldn't be okay doing it. Aluminum is another thing people get really concerned about. It's an adjuvant in vaccines used to bolster immune response, antigenic property. And there's estimates that basically based on dietary aluminum ingestion from breast milk alone, or even formula, an infant would ingest quite a bit more than they would get through the entire vaccine series. So it's not a lot of aluminum, but that's one that people think is a neurotoxin that gets in the back of people's minds a lot too. That's a problem. But again, no proof that that's actually true. So. All right, what about vaccines and big pharma? It's a big conspiracy. Well, they're profitable, but when you compare it to like a once daily PO med, it's really expensive to make vaccines. There's in fact only a couple drug companies that even do it because the profit margins are slim. So the R&D is more expensive and production's more expensive. And some economists have predicted that basically if you spend $1 on a kid vaccinating them, you're going to save much more down the road if you think about the decreased healthcare exposure costs. So I don't like to talk about economic models because I think they're kind of funny money and no one really knows if it's actually true. But some of the models out there predict billions and billions of dollars saved based on decreased vaccine or decreased healthcare costs and exposure and stuff like that. And just my example of the H influenza type B, you have prior to immunization. So you see this about as far as incident percentage goes, and then at the rate of 100,000 children less than 5 years of age, and basically it tapered off once the vaccine came. And we rarely even see this as a disease anymore. This used to be a big concern. 1 in 200 kids, invasive HIV, 66% in children under 18 months. So affecting really young kids associated with bacterial meningitis and bacteremia. And then, once we've had it involved, it's really, really rare to actually see it at all. So once one of the more common things we'd see in kids, now pretty much eradicated. Herd immunity. So what's the concept of this? So concept is vaccinating the most people to protect those who are not vaccinated, so that the disease can't spread as easily if it cannot find hosts. So if I'm not vaccinated, but everybody else is here, somebody in the room walks in with whatever, let's say I don't know, something MMR or measles. It's good in the news right now. So let's say they walk in with measles. You guys should all protect me from getting measles, right? Because it shouldn't really pass through you guys unless I walk into them too, or else I breathe the same air. Whatever. I guess it's a bad example because we're in the same room, so forget I said that. If this was the state of Minnesota, that's a better way to look at it. But anyway, the point is that we need to protect our weak-end people in our communities. So healthy people should not, and it's inappropriate if healthy people rely on herd immunity, because healthy people are the ones who are supposed to provide the barrier to our less fortunate population. So our people with cancer, are really young kids. So like I always say, kind of my end-all be-all argument against anti-vaxxers is if you have a kid who can't get a live attenuated vaccine like MMR or influenza, or not influenza, but like any of the other live ones that we talked about, then you're possibly, by not vaccinating your kids or not getting vaccinated yourself, you're risking an exposure to them and possibly a detrimental exposure to them. Is that worth it for you to crusade on something that is, not only completely not scientifically proven, but it's just kind of a very small part of the population is really in favor of this. So I don't get how you could live with yourself that night thinking that you could possibly be hurting somebody's kid who's undergoing cancer treatment. And it just blows my mind. But there are people that think that way, and you can't change them. I think there's a lot of arguments out there, and you see these people pop up on social media and whatever, and it's just probably best to say your piece and move on. But yeah, that's all I've got. Any questions about vaccines? We'll take a quick break. All right, let you get up and stretch for 5 minutes. Again, there's a few slides left, so I want to go try and get through as much as possible today.
But that's the same as you
All right, so pediatric cardiac or like the congenital heart defects and things, I don't have a lot to say from a drug perspective. A lot of it's heart failure related symptoms, and we're going to use inotropes and pressors and things to manage them. So nothing too new here, but we'll talk about it a little bit. I've got some of the defects that are common here, like left to right shunt, right to left, and just what you're looking at as far as changes in pulmonary or systemic blood flow. And then some examples: transposition of great arteries, atrial septal defects, tetralogy of Fallot, which is kind of 4 different things going on at once. A lot of these things are going to need to be corrected via surgery, so it's not a lot we're going to talk about pharmacologically, but here's some different things we can look at as far as the anatomy if you're curious as to what we're talking about here. ACE inhibitor, beta blockers, loop diuretics, symptomatic relief, very similar to how we treat adults, not a whole lot different there. So post-op congenital heart defects, usually again surgery, going to try and correct it as soon as possible. And we're looking at fluids, IV dopamine or epinephrine for blood pressure support is going to be key in the immediate phase. Then we use a lot of milrinone in kids. It works pretty well as far as a pure inotropic agent. We, of course, use it in adults too. But if somebody is hypertensive, which can happen too, you can try sodium nitroprusside, which is a nice broad spectrum vasodilator. It's really going to treat it symptomatically, provide inotropic support in that post-op period, and hopefully wean them off over time on that. So fluids, wound infection prophylaxis, just like you would any surgical candidate, and we use the same things we use in adults. We use ANSA for most patients. If they have an MRSA risk or an allergy, we'd use vancomycin. Diuresis, we can use Lasix again, would work in this situation as well. Pain control, same thing as an adult, fentanyl, probably going to be preferred in most acute situations, possibly paralytics if you need to, and electrolyte replacement as needed. That's pretty standard stuff, very similar acute care to how you treat an adult patient. Complications, you can end up with hypertension, renal failure potentially, but ideally those get avoided if you medically manage them and surgically manage them appropriately. So we can have a couple different things that happen, and a lot of this is moving into more heart failure. So we're looking at things that are ongoing that we can manage with different types of oral medications. So increased contractility, we can use digoxin just like we'd use in adults, so it gives a good inotropic effect. ACE inhibitors decrease preload. Diuretics can help with the volume, which can also help decrease preload. And ACE inhibitors also decrease afterload, and beta blockers can help decrease afterload too. So again, same stuff we're going to use. Beta blockers would be reserved for more severe cases and try and avoid them if we can, but try and get by with the other ones. Kids tend to be a little more affected by them, so more prone to bradycardic episodes and things like that. I may not be able to get as therapeutic of a dose out of them, but it's something worth trying in more of a severe case. Arrhythmias, cardiac arrest or life-affecting arrhythmias. We'll talk about ACLS during critical care a little bit, but or in emergency medicine actually, I think is where I have it slotted. But anyway, it's pretty much the same thing. The dosing is different than adults, but the medications are the same. We give lots of epinephrine and give amiodarone for arrhythmias and things like that, but we'll go through all that during emergency medicine, so don't worry about it right now. Hypertension in kids is pretty uncommon, but it's going up due to the increased prevalence in obese children. So it's about twice as common in an obese child versus a non-obese child. And of course, just like adults, dietary habits like sodium intake and activity levels are important targets for kids. Staging, usually it's based on percentile of age group, or if you're into adolescents, it's the same kind of as adults, although it's a little bit more aggressive. So over 120 over 80 would be considered hypertension for an adolescent patient. And then stage 1, again, you're going to see greater than 95 percentile of age group, and then stage 2 would be 5 millimeters mercury higher than 95% of the age group. So it wouldn't take too much to get into that stage 2 category. Treatment, very similar to adult medicine. ACE inhibitor, ARB, dihydropyridine calcium channel blocker like amlodipine, thiazide diuretics, and beta blockers would be kind of your second line. So really identical to how we treat adults. Pulmonary hypertension, we talked about this, is more of an acute thing that happens with our different respiratory illnesses that are occurring in our neonates. And as far as inpatient therapy, pressor support can help with the heart failure component of it. So usually there's, again, backed up on the pulmonary artery, which can cause some ventricular dysfunction, and that can be improved with inotropes such as dopamine, dobutamine, or milrinone. Inhaled nitric oxide can also help alleviate some of that pressure as well. It's not really sustainable to do that, any of those therapies. So outpatient, we're going to treat it very similar to adults. So I'm not going to ask you any questions on outpatient pediatric pulmonary hypertension because it's super rare, but just in case you're curious, it is there. And it is something that does happen in peds, especially in the inpatient side pretty commonly. So if you work pediatric critical care, it's something you'll definitely see. All right, some other topics and random things we haven't really talked about. Just covering a couple things in a couple specific disease states for kids. So general pain management with kids. Don't assume that children's nervous systems don't experience pain. They do. Children will have memory of pain, so it's not that they'll just forget the next day that they were in pain. Children will not necessarily become easily addicted to narcotics, so you can use narcotics in kids. And we just need to treat kids like you would treat an adult in pain. So you need to routinely assess it, treat it, stay on top of it. Pediatric pain scales can be tricky, and a lot of times you're going off of how the patient's looking as far as what types of movements they're doing, facial grimacing, things like that. Of course, they aren't going to tell you 1 through 10 unless they're older. They might be able to tell you that, but for the most part, you're going to have to figure it out based on. There's a lot of different pain scales that look at pediatric criteria as well, and will tell you basically what they're doing and how much pain they appear to be in based on certain symptoms that they might be experiencing or exhibiting. Treatment options for kids, they're all really the same. There's no, other than aspirin, which we don't really use for adult analgesia anyway, you can pretty much use everything for a kid you could use for an adult. So no restrictions there. Opioid or non-opioid therapy, acetaminophen and ibuprofen, 10 to 15 mg per kg per dose, 5 to 10 mg per kg per dose, Q6 hours for ibuprofen. If you want to know any pediatric doses, these are probably good ones to have in the back of your head. Just because they're so common. And if you get somebody who calls you, a friend or a relative, you're like, oh, my kid's got a fever, how much Tylenol can I give them? And they don't feel like reading the back of the bottle, which is usually conservative, to be honest. Whenever I do the mg per kg dosing, I'm always giving quite a bit more than what it says, which not quite a bit. I'm not like overdosing my kids, but it's more than what they would recommend on the bottle. But that's what they would give if you went into the emergency department. So obviously they're going to be more conservative. One thing I will say is that with kids, you might read occasionally they recommend not to mix acetaminophen and ibuprofen. There's no reason you can't do that. The reason why they tell people not to is they're scared somebody's going to forget what they gave somebody and then double up on the dose and overdose their kid accidentally on Tylenol, which is, can be problematic for liver failure. So you have the option of, understanding how reliable your patient's family members are, and if they can think they could maybe set an alarm system or a reminder system. Like even when I was doing it, I had an email or a document open, and I was just typing in on my phone every time I was giving. My kid had a fever last, so I could remember. And I was pretty sure I could remember myself, but you never want to be like, oh, which one did I give last time? And what we did was we ended up kind of alternating every 3 hours. And so you can certainly do that, especially if you've got a fever that's viral and not going to really respond to anything else. You got to try and make your kid comfortable if you can. So certainly okay to use. Other NSAIDs like naproxen and ketorolac are fine to use in kids. We just use ibuprofen a lot. It's common. It's easy to find over the counter. It comes in good flavored liquids, so kids tend to like it, I think. Sometimes for really little neonates, they'll use just sugar water for procedures. So for specifically circumcision immediately after birth, they use just a little bit of sugar water, which seems to actually clinically has been shown to reduce what they assess for pain in neonates, so it's kind of interesting. Opioids, pretty much everything can be used for kids. All of them are okay. You might see methadone for kids if you work with an addicted mother who delivers, or work with the kid of an addicted mother who delivers. Taste is always a consideration too. I have not actually gone out and tasted lots of different opioids, and fortunately, we should say, I think, but there are a number of different oral solutions. Like there's a Percocet oral, and there's a lot of them. I think a lot of them have higher alcohol concentrations. They might not taste all that great, but there are options available for kids that way. Okay. So those are just some basic pain things. Let's talk about cystic fibrosis, because it's sort of something that's going to mainly affect pediatrics, although you can definitely live into your adult years with CF. So what it is, mutation in the cystic fibrosis transmembrane regulator protein, which causes complex chloride channels to work inappropriately. And what happens is you get a thick, viscous secretion in lungs, pancreas, liver, intestines, and reproductive tract. So those are all your primary targets of symptoms. The lungs being the one that are going to be the most problematic for quality of life, and ultimately are probably going to cause the most mortality in these patients. So both sexes are generally still fertile, but usually have a delayed onset of puberty due to the effects in the reproductive tract. May require special treatment. It is an autosomal recessive disease, primarily affecting Caucasian people, and there is that ethical dilemma of, if you have carrier history, it's one of those things you can get tested for genetically, and they ask you if you ever want to get tested for this and see if you have this exposure. I know some people do, like my brother and his wife did. My wife and I decided not to. We don't have any history in our family, so we're like, well, the odds are really slim, but you could never know if you're a carrier, and having a child with cystic fibrosis is not going to be easy for sure. Mean life expectancy is about 40 years, and that can depend on the treatment center. Minnesota, actually, the Fairview has done some really good work with CF patients over the years, and they've been one of the leaders nationwide on some of the CF treatments. But depending on what center you go, some families will actually move to a really good city a city that has a really good CF center, just because the life expectancy is so much higher. You'd think it would be more standardized, but I don't think it's quite gotten there yet. And hopefully we'll get more and more better about it, but at this point I don't think it's changed a whole lot. There's really just centers that are focusing specifically on it. All right, we kind of talked about these mucus clogged things. So you get these thick secretions in the respiratory tract, which harbor all sorts of bacteria, and that's really the big problem here, and can prevent functional breathing. And then you get a number of other things too. Genetics. You guys have probably talked about this as a genetic example at some point during your schooling. I'm sure it's kind of a famous one, a famous ethical question too. So treatment, pancreas involvement, we can replace the pancreas with a number of different things. So we can give pancreatic enzymes orally with people with meals, and those are lipase, protease, and amylase to dissolve fats, proteins, and carbohydrates. A number of different dosages, pretty easy, pretty effective. Diabetes, high prevalence of that due to the shutting down of the pancreas production of insulin. So you can treat it with insulin. It'd be very similar to a type 1 diabetic patient. Not all uncommon to see those two kind of go hand in hand with CF patients. GI involvement, you can get some other things like GERD, and symptomatic relief is fine, or symptomatic treatment's fine for that, how you normally would. Cirrhosis of the liver is common with advanced disease. There's a medication called ursodiol, which decreases cholesterol reabsorption and can dissolve bile stones. I'm not too concerned you know much about ursodiol, other than that it exists, and it's used for CF-related liver problems. All right, pulmonary involvement. So this again is the big one. So you have obstruction, inflammation, and infection, and ultimately these CF patients get really, really nasty microorganisms growing in their lungs, like super odd resistant things that are resistant to every antibiotic on the planet. It gets really difficult to treat them, and on top of that, it's difficult to get systemic antibiotics into the lungs because you can penetrate the pulmonary vasculature, but if you have a big, basically think of it like a big medium of junk in the bottom of your lungs growing stuff, it's hard to get antibiotic into there. So respiratory treatments and nebulizer treatments are key for these patients, and getting those secretions out of the lungs on top of that. So percussive therapy, so kids will wear percussive vests that actually pound the lungs physically, and that can help loosen the secretions and allow them to get suctioned out or to cough them up. Bronchodilators like albuterol and ipratropium can help, and specifically you can dilate your lungs before you use percussion to open things up a little bit. There's a medication called Dornase alpha, which is really expensive, but it's a good medication for these patients. The biologic agent that's inhaled that cleaves the DNA of this viscous mucus. So it's kind of an interesting product designed specifically for CF patients that reduces that viscosity. Hypertonic saline, 7% nebulization, also improves mucus clearance. The hypertonic can help create a concentration gradient, which can loosen up the mucus a little bit more by pulling more fluid into the lungs. And then there's N-acetylcysteine or mucomist, which we use for treating Tylenol overdoses, but you can also give it in inhaled form here. It cleaves the disulfide bonds within the secretion DNA to help liquefy it a little bit and again help get it out. So all these things really do pretty much the same thing. All these, the last 3 bullet points, they're all loosening up mucus. Then you're using percussion and bronchodilators to open up the lungs and help get that, cough it up basically. You can suction it out too in more severe cases. These are what the vests look like, if you've ever seen one or never seen one, but they kind of look like a life jacket with a pneumatic hose hooked up to it. And you can see she's got they've got the nebulizers going at the same time to help open up the airways. Corticosteroids can be used inhaled or oral for acute exacerbations, kind of like an asthma exacerbation, not recommended for chronic use. And then antimicrobials. So again, we're looking at really broad spectrum approach here. When you get a CF patient who's got a systemic illness, so you kind of live with the fact that the CF patient is probably going to have a lot of junk in their lungs almost at any given time, but a lot of times it's colonization, it's not necessarily infection. That can overgrow and lead to infection, of course, and that's where we get in trouble. So chronic suppressive therapy is what we try to use. So they'll use Toby nebs or tobramycin nebs, which tobramycin has a pretty decent broad spectrum of coverage, and it is an aminoglycoside which can be nephrotoxic, but when you give it via the lungs, you don't have much of it systemically. So it's getting really to the site of action where you want it, and it works quite well down there. And again, very broad spectrum, covers Pseudomonas, covers other gram-negative resistant pathogens. So that's a good suppressive therapy. So they'll usually be on Toby nebs every day. Azithromycin can be used as well. Macrolides tend to have what we call good biofilm penetration. So if you have a bunch of bacteria kind of in a film on something, in this case the lungs, it can get into that film and penetrate those deeper layers, as opposed to other antibiotics might not do as good of a job of getting in there. So synergistically they tend to work. But azithromycin's coverage is a little bit iffy, and it doesn't really cover some of these more advanced pathogens. It doesn't cover Pseudomonas at all, and so the question is what exactly are you getting from it? But you can maybe make the argument that there might be some synergy there between the macrolide plus the aminoglycoside. All right. I want to talk really briefly about sickle cell disease. So sickle cell disease is something that will affect children if they have it. And of course, it can affect adults as well. Most common in patients with African heritage. And you get complications associated with the sickle cells getting stuck in microvasculature. So think about end areas, so end organ damage. Hands and feet can get really severe pain syndrome from this. Due to all the nerve endings in your hands and the feet, and the fact that there can be inflammation, and I've seen a lot of sickle cell patients come into our ER, and the amount of hydromorphone and fentanyl we give these people is kind of insane, but that's what it takes in some cases. Usually they aren't on it chronically, fortunately, but they get a flare, and then there's really not much that touches this other than really pretty heavy opioids. For men, priapism is a big problem too, due to the decreasing blood flow out of the penis, and so you can get possible necrosis in that area as well, which can of course be highly problematic. And then sickle cell is probably again something people have covered in almost every biology class, because it's kind of an interesting disease where your cells look like a sickle, they get stuck places, and then you get occlusion. So lots of other issues with this as far as possible what they call chest syndrome. So blood vessels get occluded, you can get infections, pulmonary infections. We're going to treat it very similar like we would any type of pulmonary infection. There's no real difference here. We're not looking at like an immunocompromised population or anything. It's just a different mechanism that's causing it. Stroke is increased substantially as well, and usually they treat this by transfusing blood. They don't really do anything else. That's the best way to get rid of the sickle cells and get blood restored to the area, because it's not a clot, it's just can't really bust it like a clot like you normally would, like with alteplase, because the blood cells aren't necessarily clotted together; they're just sort of stuck. They can form a clot, but it's just a different mechanism. Priapism, you can aspirate, you can irrigate, you can give a vasoconstrictor locally to the area. That usually doesn't help either. You're just going to have to consult urology probably for that one. And splenic sequestration, so blocked microvascular. This can possibly be life-threatening because you can get a really rapidly absorbing abdomen. So this is going to be another thing where you're probably going to have to do surgery or some sort of transfusion. Pain, again, it's probably going to be the thing you're going to see the most if you work in like Minneapolis or something where we have a high, we have a big Somali population, we have some other African populations as well. You might see this from time to time, and again, the pain syndrome is pretty high tolerance of pain, so they're going to need lots of opioids. You can try NSAIDs too, you probably aren't going to touch it. Hydration can help restore some volume to the blood, maybe help, if you think about it, loosen things up a little bit, but at the same time, you might just need to treat through it. Chronic prophylaxis. Hydroxyurea is a drug that sickle cell patients might be on. That's an anti-metabolite that alters red blood cell function and can help prevent the sickle cells from forming in some cases. So if you ever see a patient on that, they aren't on much else, it's probably because they're sickle cell. All right, I'm not really gonna. I think I'm gonna ask like maybe one question on sickle cell. It's probably pain related, so just so you know, I don't really care you know much more than that. A lot of it's procedural. I just think it's kind of interesting to talk about. And then psych topics, we covered a lot of this. Basically, for neuro stuff, seizures. I think I mentioned this during the neuro lecture, but pretty much any AED we can use in kids. And febrile seizures are really common. You want to treat an acute febrile seizure like you would a normal seizure, and you also want to treat the fever, but you don't need to do preventive therapy. That's really controversial and usually not needed. There might be weird instances where somebody has chronic fevers where they get a lot of seizures with it. Maybe that's the case, or maybe they have some sort of a really bad viral illness where they have a prolonged seizure and they keep seizing. They might try to do something more longer acting like a Keppra to get them through it, but over time the odds of them needing to stay on it pretty slim to none. Depression, most common antidepressants might be used in children, and I think I mentioned this, but a lot of them actually do have some data in kids. Like I think Prozac's got the best of it, fluoxetine's got the best, and it's down to 8 years old is the bottom end where they've actually studied it in kids to be effective and relatively safe. We talked about the risk of suicide in young adults and adolescents too, so there's always that as well. In ADHD, we talked about that. That's pretty much all, well, heavily pediatric focused, right? Yes?
When a patient comes in a seizure, do you usually do an AED or a benzo? Like right away?
Usually a benzo. They're going to be the fastest acting.
Yeah.
Although sometimes you get a case where somebody's come in and they've gotten midazolam. Usually, our EMS usually carry midazolam because it's useful for a lot of different things, including seizures. So they might have gotten a lot of midazolam already. If it's not stopping it, you could try either giving something more long-acting like diazepam or lorazepam, or you could just go straight to Keppra. The problem is that like if we're going to give Keppra, we don't keep that readily available. Like you can give a small dose of benzo really quickly and it's effective. We have to make up like a bag of Keppra and get it from our IV room, so there's a little bit of time transit in there. So that's really the issue with it. But otherwise, yeah, if you've tried benzos and it's not working, or if you've suppressed a seizure and you're afraid of a recurrence and they currently aren't seizing, they might give a dose of something like Keppra right away or an AED or valproic acid. Yeah.
So is that a situation where if you have a child that comes in and you determine you get their seizure stopped, but they're still febrile?
Yeah.
You're probably going to give an AED.
I think it's going to be a clinical decision on the time. I think have they gotten antipyretics? Are they responding to the antipyretics? How high is their fever? How likely is it that they're going to go into another seizure? There's probably a number of things that they look at when they think about that. But I think you could. I mean, one dose of like valproic acid or Keppra IV is pretty safe, so you aren't really going to cause any harm. If you wanted something longer to suppress it, it's going to last longer. But you might not have to do it in all cases. So. Is that the last slide? Yes. Okay. So peds topics, I'm going to ask questions sort of all over the place on these. And as far as like ID, just know kind of the primary treatment. So if I ask you about bacteremia, focus on some of those broad spectrum approaches, and then some of the more narrow things for the things like whooping cough and some of those types. But yeah, you'll have, I think it's all pretty laid out in there. I don't ask anything I think too crazy. CF might be the hardest one because there's so many treatments, but focus on which drugs loosen mucus. Like be able to recognize if I asked you if I gave you several options in there, and if I gave a patient's home regimen, see if something was missing. So like if they didn't have, remember to think about mucolytic agents, but also like tobramycin, tobinubs, and think about some of those other things too. So being able to recognize what might be missing from a home regimen for a CF patient. I do the cases a little different. I don't have like a case document, but I have a little PowerPoint from last year that I'll post with some review stuff, and I have a video where I explain it as well. So that should take the place of the actual cases, but it's very similar in how I would normally do it. It's just a PowerPoint. So keep your eyes open for that. I'll post that shortly.
How many questions?
I don't know how many questions are on this test. I totally forgot.